So thank you all so much for joining us today for Navigating the Treatment of Substance Use Disorders During Pregnancy, hosted by HCET with presenter Brooke Schaefer. My name is Jordan Greenwald. I am the Training and Community Engagement Manager at HCET, and I will be moderating the webinar today. I do want to briefly introduce you to healthcare education and training for those of you that might not be familiar with our work. Our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And we are an organization of passionate people who are proactive in our belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. This webinar does have closed captions available if you need them. So to enable them on your screen, you click the live transcript button at the bottom of your screen, then click show subtitle, and you can change the settings by clicking subtitle settings. Throughout the presentation, we also encourage you to send your questions either via the chat or the Q&A box, which I do believe I enabled for this, but if I did not, just feel free to send them via the chat. But if you'd like to submit a question, then that Q&A box is there. Just hover over the main screen, select the Q&A icon at the bottom, and then it should appear. You are able to also send questions anonymously through this feature, and we will make sure all your questions get answered at the end, or if Brooke wants to answer it in the middle of the presentation, we will do that as well. So just know your question will not get missed. We'd also love if you follow us on our various social media accounts to keep up to date with the newest information and events. Now, I just want to quickly review some housekeeping information. So a link to complete an event eval will be sent to you in the chat at the end of this event, as well as via email following the training. Your feedback is greatly appreciated and helps us form future events, so please fill that out. Archived presentations and a list of upcoming events can be viewed on our website. And if you have any technical difficulties during this presentation, please feel free to reach out to me via the chat or contact updates@hcet.org. Now I'd like to introduce you to your presenter for today. Brooke Schaefer is the founder and CEO of Pendleton Collaborative, a healthcare innovation group focused on the well-being of patients and staff. She's also the director of perinatal substance use disorders for Community Health Network and oversees Choice, a program supporting mothers with substance use disorders. Brooke, a nurse practitioner with a master's degree in business, resides in central Indiana and embraces a lively farm life with her husband, 4 children, and various animals. Without further ado, I will be turning things over to Brooke.
Excellent. All right, let me make sure that I am sharing my slides here properly with you. There we go. And can you see the slides okay? Excellent. Okay. Jordan, thank you for that introduction. I'm really glad to be here today. I live on a little farm just outside of Indianapolis, and I just got one of those rabbits that's called an English lop that has the ears that are like 12 inches long, and they trip on their ears. Like, he's so cute. I'm freaking out. So if I look extra sparkly-eyed today, I'm thinking about that cute little bunny trying to hop around with those giant ears. In my professional life, I provide direct patient care. At least once a week, I am actively taking care of patients face-to-face. That's a really important part of my career because I love the patients that I serve, and I'm very devoted to that care. So I am right there all the time, face-to-face with these patients. I make myself very accessible to them. I did not grow up in a household with a history of substance use disorder in my home. I did have a very close friend who struggled with some opiate use disorder, which she has overcome for many years. But I really needed my patients to be a part of teaching me about this care and the services that they need. So much of what I know has been taught from just having a curious heart and really trying to engage with the people that I'm caring for. I have been running Choice, which is, again, a treatment program for mothers with substance use disorders, specializing in pregnancy for the last almost 6 years. So we have really got to grow our program over time and really get to be part of the integrated services we're providing these moms. with all that said, I am super excited to present to you guys, but definitely feel free to participate. I really want to hear you come off mute and ask a question. I have 4 kids, so I'm very used to being interrupted quite frequently. So I feel free to interrupt because your questions are very important. You can definitely put them in the chat if you prefer, but it is difficult to present and also monitor the chat box. So Jordan, if you see something in there that looks like it is a question that needs to be asked, please just interrupt and ask me. I love discussion. Frequently, when I present, the best education comes when someone asks a question that really helps the conversation go in a different direction. So the slides are not the most important thing. The conversation we're going to have with each other is the most important. Let's make sure that this is going to progress. So I would like to talk a little bit about substance use disorder itself. And one of the things that I often get pushback from for people who do not generally work with those with substance use disorders is they ask questions to me like, why don't people just quit? And I'll hear that worded differently. Sometimes they'll say, if she really loved her baby, she would stop using substances. Or I'll hear people say, I didn't even drink Diet Coke when I was pregnant. Why can't somebody give up all these substances when they're pregnant? And I really, really want to urge you to think about this with an open mind of taking into account your own biases about substance use disorder. Before you can really care for these patients, you've got to think about where you're coming to this from. What is your history with substance use disorder? Do you have a personal experience? Do you have a family experience? What are the biases that you carry around that you really need to examine in order to care for these people? And one of the ones that I see frequently, whether people will admit it out loud or not, is the concept of addiction as a moral failure. So, why are substances so hard for people to quit? It is such a multifaceted thing. And I know you'll hear addiction called a disease fairly frequently. I have some patients that really dislike that because that's like, for them, they say that means that I can't overcome this. It's just a disease I'm going to carry my whole life. And even if I fight it, it's still going to come to get me. They don't like that concept. They want to feel more engaged with what's happening. I have other people who say, absolutely, the disease concept makes sense to me. I'm not asking you to accept the concept of addiction as a disease for sure. That's something too. When I present to you guys, you don't have to agree with anything I say, right? You can look at every word I say to you today and say, oh, I don't agree. I don't agree. But I want you to at least be thinking about it. Let it kind of get in your mind some, because addiction itself is so complicated. It often stems from a history of trauma that is extremely significant. If you have not heard of ACE scores before, so that's ACE, an ACE score is an adverse childhood experience, or sometimes I've heard it written as events. So adverse childhood experiences or events. And these are things that happen to you prior to the age of 18 that you have absolutely no input in. So were you, some of them, for example, it's a scale of 1 to 10, and you get a score of 1 for each of these events that happened to you. One of them is, did you grow up in a household where a parent had a substance use disorder? Okay. Did you grow up in a household where there was a divorce? Were you physically abused as a child? Were you neglected as a child? Sexual assault, like all these things. Did you have a parent that was a loved, close care provider that was incarcerated? These are all things that you as a child have absolutely no control over. And the higher your ACE score, the greater the link to a substance use disorder down the road. It doesn't mean that there's going to be people on this call right now who say, Brooke, I know for a fact I have an ACE score of 9, 10, like super high numbers. And you're going to say, but I don't have a substance use disorder. I rose above. That's incredible because it is way more complicated for someone with a high ACE score to rise above those challenges than for someone who doesn't. I saw it shown once in a YouTube video where it was like all these kids were all standing there and the coach said, okay, we're going to have a race. And it's a 200-meter race, except every kid who has a divorced family take 3 steps back. Every kid who grew up in a household where you had a family member incarcerated take 3 more steps back. Every kid, and he kept making the kids step back. And this wasn't real. Okay. This was just a video to demonstrate this. They weren't actually making these kids do this in front of each other. And then he said, okay, now I'm going to say go and we're going to run this race. Well, the one kids were starting at the 200-meter line and the other kids were way further back. It doesn't mean that the kid who's way further back couldn't somehow be the fastest kid and beat everybody. It just means it's going to be a lot harder. So ACE scores are definitely something worth investigating more anytime you're providing care to these patients. That trauma link is significant. And you can see here, I'm talking about ACE score, but you're also looking at environment. So there are people who grow up in environments that just really, or are living in environments where substances are readily available, where people in that environment are readily using substances, where it's part of the norm of whatever environment they're living in. That could be as a child or as an adult. People with unstable housing are frequently in situations that are less safe in regard to their housing. And that means settling for situations that maybe you wouldn't want to live in, but you really don't have much you don't have much option in that. And those environments can be really significant. That's something I'm talking about with my patients all the time is, are you living in a safe, sober place? If the answer is no, what can we do to help you so that you are living in a safe, sober place? There is definitely an aspect of this that is a decision. You do decide, am I going to use a substance or not? But the risk factor that you would say yes goes up significantly if you have a history of trauma, elevated ACE scores, and you're in an environment where this is readily available. Of course, genetics has a factor in this. So you can't say alone, well, they made the decision to use. It's not as simple as just a decision. There's the genetics factor in this. If you come from a family history of substance use disorder, you are statistically way more likely to yourself have a substance use disorder. Even if you, like, even in adoption studies where kids were raised in households where there is no trauma, no ACE score, no environmental issues, those kids still have a higher risk of substance use disorder, simply with that genetic factor existing. If you have all these things together, genetic history, trauma, ACE score elevated, environment, and you have made the decision to utilize these substances, man, you've got all the things in place for a substance use disorder. Frequently, the patients that I'm caring for, they have all these things in place. When we start talking about their family histories, when we talk about their genetics, their ACE scores, these patients are definitely extremely high risk patients. Even if all you knew were the answers to these questions, you would have a pretty strong predictive factor as to if they would develop a substance use disorder. This information is important because it's something that's important when you're counseling kids. I'll tell my children, guys, grandpa was not my father. My husband's father was an alcoholic. You've got to be very careful with alcohol in your life. There's a family history of substance use disorder. These are things they need to know. So many factors work together to equal substance use disorder, which is why it's extremely difficult to stop using. I always tell my patients when they first come into care, I always say, if it was as simple as just quitting, you would have done that already. It's more complicated than that to stop using substances. And so how are we going to work together as a team to really make sure that these substances are not a part of your life anymore? We've got to change many different factors. You'll hear in like AA world, so Alcoholics Anonymous, they'll use phrases like, you got to change your people, places, and things, which is actually a really interesting concept because it's very easy to say that. You got to change your people, places, and things. It's very difficult to do that, right? You need money if you're going to move. You need a rehab to go to. You need some pretty major, significant changes. That's why I'll see some patients that when they become incarcerated, they do really well because they've changed all their people, places, things. They do all the programming available to them. And we work closely with some of our area jails. If they have moms who are incarcerated, who are currently pregnant, they will bring them to us for their OB care and their addiction treatment. And I've seen several of them just thrive under that environment of structure and programming. And then when they leave incarceration, if they go right back to the people, places, things that they were in before, that's when things start to become more complicated. I want to talk specifically about the main substances that we're seeing in patient drug screens right now. We are primarily seeing fentanyl. So you will see patients, my patients will come in and say, yeah, I'm using heroin. And I often ask my patients, hey, when we drug screen you today, what would you expect me to see? And then I'll also talk to them about, what's your drug of choice? Because sometimes patients will have what we call, a drug screen that has everything positive on it. And I'll say, okay, do you have a preference? Is there a substance that you would seek first over others? And they'll tell me, oh, heroin, opiates. Sometimes they'll say fentanyl, but fentanyl is a very tricky substance because this is not at all the same as the fentanyl that we're seeing in like in a hospital. So a lot of mamas, when they come in to deliver their babies, they may get a single dose of fentanyl during the delivery process, or maybe even a couple. That's for pain control. This is hospital grade fentanyl. It's very well regulated. It's extremely carefully made and extremely carefully dosed. So it's very predictable medication. The fentanyl that patients are using on the streets is a totally different substance. This is a synthetically made, it is a derivative of the fentanyl that you're seeing in the hospital, but it's a synthetically made, very highly concentrated substance. When I drug screen my patients right now, we are looking, so fentanyl, when we're looking at their levels, if my patients are actively using fentanyl on the streets, usually their levels are so high that they are unmeasurably high. So their concentration of fentanyl in their system is unmeasurably high. If they had been given a dose of fentanyl in the hospital, their level might be, 5, 10, 20 maybe. And then there's the drug screen for fentanyl that I currently use stops measuring at 500. It just says greater than 500. Almost all my patients are greater than 500. So that when they first come into care. So that's how concentrated this fentanyl is. Fentanyl does not show up on a traditional drug screen. Okay, they've just come out with a point of care fentanyl test that is what's called CLIA approved, which means that most doctors' offices are going to be able to utilize it now. They've just released it. It just got FDA certified. There are places where you can do point of care fentanyl testing. You just can't do it if you're using insurance to bill these tests. So it gets very tricky about billing patients for fentanyl testing. I kept running into issues where my patients would come in for care. They would tell me, Brooke, I used fentanyl in the parking lot before I came up here, or I used heroin right before I walked up to here. And I would say, okay, but your drug screen's negative for everything. And they're like, I'm telling you, that was an opiate. I know what an opiate feels like. That was heroin. I know what it feels like. And finally, it happened a few times. And then I got a patient who said, it's not heroin, it's fentanyl. She goes, when I go to the methadone treatment center, I test negative for all substances because fentanyl doesn't come up on the drug screen. She said, you need to call your lab and ask them. Like, okay, all right. So I called the lab and the lab was like, oh yeah, the synthetic fentanyl that's on the streets right now actually doesn't show up as an opiate in a traditional point of care drug screen. Point of care would mean that it just tells you yes or no if the substance is present. The only way that we could find fentanyl in a drug screen was to send out a confirmation test specific for fentanyl, and then it would come back positive. Now we test everybody. But in the beginning, fentanyl really got past us for quite a long time because it did not show up on drug screens. And it's really difficult to help these patients when, insurance would be denying their care because they were coming up negative for all substances. So why do we need to prescribe medications to treat substance use disorder? Because fentanyl was hiding in there. The other thing with the fentanyl is patients will look at you and say, I'm taking Roxy's. I'm taking several Roxy's a day, Roxycodone. And then they're only testing positive for fentanyl. So what's happened somewhere along the line is illegal drug manufacturers have gotten pill presses. And the theory is through these 3D printers, they're printing off pill presses. And they're making pressed pills that are completely concentrated fentanyl. But they are using these pill presses to send them out. Oh, thank you. They're using these pill presses to send out these pills that look like they're a substance, but they're actually pressed fentanyl pills. So these pressed pills a patient will look me square in the eye and say, no, I would never take fentanyl. I would never take heroin. That's what they don't realize is that's exactly what they're taking. They are taking fentanyl. And so I've had patients that are like, absolutely no way, I would never do that. And you're like, it is not what you think it is. And that's so tricky. That's so hard for patients. And that's such a complex process. The withdrawal from fentanyl is so hard to watch. These patients, I don't know if anybody on this call, I'm not sure what all of you do professionally or what your experience is with people who are struggling with fentanyl use, but the face-to-face, when you're looking at someone when they're withdrawing from fentanyl, it is horrible. And I never thought there would come a day in my life where I would think I miss black tar heroin. But black tar heroin, when people withdrawed off that, it was still terrible, but it was nothing like what we're seeing now. The fentanyl withdrawal is so hard to watch. We've increased the comfort, and we're going to talk about this in more detail, but The comfort medications that we have to give these women now to withdraw off the fentanyl is so much heavier, so much more than we had to do with heroin. The withdrawal with heroin was so much faster. But fentanyl, you will see patients that are 48 hours from their last use. They will look you in the eye and say, I feel terrible. I am withdrawing so bad, but there's still so much fentanyl in their receptors. I call it sticky. That is not a professional term. That is not a medical, that is just a me thing. Okay. So if you Google sticky fentanyl, you are not going to find anything. Okay. That's just a phrase that I use. But the way that fentanyl sticks in that opiate receptor is so complex. It will not leave that receptor the way that a normal opiate would. So these patients will withdraw for days, and it is very, very significant, the symptoms they're having. If they are in their third trimester of pregnancy, if they are withdrawing off fentanyl without any comfort medications, they're at extremely high risk to go into labor because it is so difficult on their body that it often kicks them into labor. So women withdrawing who are pregnant in third trimester really need to be medically supervised extremely closely if they are coming off fentanyl, because it can have very serious impacts and premature deliveries for these moms. Again, don't forget, guys, please put any message, any comments you have in the chat, unmute and ask me questions. Glad to have any conversation here. Let me check time too, because you know I like to get going. Okay. So I want to talk to you specifically about the medication that we primarily use to treat opiate use disorder. This medication's generic name is buprenorphine. Okay. Let me tell you that when I have a learning disability and I really struggle with words that are like, have a ton of syllables like that word. I literally had to look in the mirror and say it when I first started this buprenorphine, like 100 times to get my mouth to say it right, because I want to say just like buprenorphine, but it comes together. So buprenorphine, you may have heard it. You may have heard its name brands discussed before. Name brands like Subutex, Suboxone, Sublocade. There's several different versions. We're going to talk about those a little bit. But I want to talk to you specifically about this medication. It has a lot of misunderstandings about how it works. There are some injectable forms of this medication. Currently, right now on the market, there are two options, but this will change. Okay. So this is always a moving target when it comes to this medication. Both of them have merits, and they both protect patients from the pitfalls of daily use. So I will get moms sometimes who have delivered their babies, because neither of these are approved in pregnancy right now. So once a mom has delivered her baby, she'll say to me, like, I had one mom who said, please put me on one of the injectables because I don't want anyone in my family to know that I have these pills, because nobody can ask me to borrow a pill if I don't have any pills. So my family's always coming around trying to get me to give them a Suboxone pill, give them a Subutex pill. Well, I can't if I don't have any. So please just give me an injectable. Oh, that's great. I had another mom who wanted to be on this injectable medication because she didn't want these pills around her house. She didn't want her kids to accidentally get into these bottles of pills and there be issues. She wanted to just make sure that was one less thing that she had to worry about. I've had another mom who wanted to be on injectables because she didn't want the daily maintenance of taking pills every day. Great. These medications are impossible to divert. So diversion is taking a medication that has been prescribed to you and using it or manipulating it in a way that it wasn't meant to be taken as. So like as your doctor, I'm writing you a prescription for Subutex, but you're selling it to your neighbor and using that excess money to buy fentanyl. Okay, that's a problem. I've had patients before where they were selling their Subutex script because their rent was due. So they would take a small amount of their medications and then they would sell the prescription so they could pay their rent. If I was desperate to keep a roof over my kids' house, a roof over my kids' heads, I can't say I wouldn't think of the same idea. I mean, sometimes desperation, desperate times can lead to desperate measures. We try really hard to work with our families so that they're not in situations where they are that desperate, right? But this injectable buprenorphine, they are great products for people who are living in residential recoveries or incarcerated or in any kind of situation where diversion is a really big problem, because you can't divert this. You can't get this shot in your arm, take it out and give it to somebody else. It's not how it works. So these injectable buprenorphine products are fantastic. I like them a lot. We use them whenever we can, but they're not for everybody. Again, there's two. One is called Brixadi, and it is a weekly or monthly shot. So patients can get it every week, or they can get it once a month. You can give it at different sites in your body, like then you can Sublocade. Sublocade has to be given in your belly, like in the meat of your belly. Brixadi has several different dosing options. It gives you a little bit more of an option of how to regulate their medications. Sublocade has to be given in the belly, and it's a once a month shot. So it's a little bit firmer how it's given, but it, both work extremely well, especially for someone who's at high risk for diversion. Then we talk about medications like Subutex and Suboxone. So people get really confused about these, and I've had patients who are absolutely certain that I don't know what I'm talking about on this one. And I respect that. I kind of like when a patient looks at me and goes, I don't believe you. Because I feel like that's really brave. That's a good sign of somebody who is going to advocate for themselves, somebody who is not just going to roll over and do anything I tell them. They're engaged and they're only going to do something if they believe in what I'm telling them, which means I need to be on my A game. So I never, ever mind a patient who tells me, I don't believe you. Okay, you don't have to. We usually get there together. But the Subutex and the Suboxone, so they both have the same working ingredient, okay? Both those two medicines have buprenorphine in them. But Suboxone has one extra component. It has a little bit of Narcan in it, just a smidge of Narcan. So Narcan is that medicine that you give when you're trying to reverse an overdose. So let's say that you find somebody overdosing and you see the Narcan. And I went like this because it's a medicine that goes up your nostril. P.S. If you're my 20-year-old daughter, I taught her when she was about 16 how to give Narcan, and she was like, so do you give, like, she was used to taking Flonase as a kid, where you put one spray up one nostril, one spray up the other. And she was like, so do you like give a Narcan up one nose and then up? No, baby, just one shot of the Narcan right in one side of the nostril. So Suboxone has a little bit of Narcan in it, but that Narcan is sleeping. Okay, think about this little red panda. He's just sleeping on a log doing nothing. If you take that Suboxone tablet by mouth, the Narcan does nothing. So people will say, oh, well, the reason Suboxone works is because it has a blocker. That is not why Suboxone works. Subutex and Suboxone work exactly the same. It's just that Suboxone has this little bit of Narcan in it that is asleep if you take it by mouth. If you take it in your vein, so if you inject it into your vein, that Suboxone, this might be blocking your view of this slide. If you shoot up Suboxone, it goes into your vein and that Narcan becomes awake like this leopard, which P.S. I meant to pull a picture of a cheetah, but I accidentally pulled a picture of a leopard. And then when I saw it, I'm like, that's not a cheetah. Okay, don't call it a cheetah. It's a leopard. So, okay, I got my animals right. So why put the Narcan in the Suboxone? What's the point of it? It's put in there specifically as a deterrent so people are not injecting it. You can inject Subutex. You cannot inject Suboxone without giving yourself a dose of Narcan. So why are so many people saying they're allergic to Suboxone? With my patients, we follow the rules of the American Academy of OBGYN, okay? So we give patients, that group recommends that you give Subutex to pregnant patients and Suboxone to non-pregnant patients. So I will have patients that at the end of their pregnancy, they've been on Subutex for several months. They'll say to me, I'm allergic to Suboxone. I can't have it. Oftentimes patients will have a really negative experience with Suboxone when they are getting it off the streets. So maybe they're actively using fentanyl. They buy a Suboxone pill. It makes them terribly sick. And so I want to talk to you about why that aspect exists. I will say that Subutex has a much higher street value than Suboxone. So why do we prescribe it? Because that is what the American Academy of OBGYNs recommends that we do. And we respect their recommendations. We do exactly what they tell us to do. So let's talk a little bit about how this medicine works within the system. I promise you that I am going to do my very best to not bore you with this, because I hate phrases like it's a partial agonist that attaches to the mu receptor. Like, no, who follows that? I'm sure there are people who are clever enough, but for me, if I hear you start talking about agonists and partial receptors, I'm leaving mentally the conversation. So I want you to think about it like this. This cul-de-sac is your opiate receptor, okay? You've got your vein along the bottom, which would be like your bloodstream is the street in front of the cul-de-sac. And the cul-de-sac is the opiate receptor. You got this great little neighborhood. Everything in the cul-de-sac is very tidy. Everything makes sense. For some reason, this one person's parked in the street of the cul-de-sac, but that's okay. They're still parked neatly. So everything is fine in this cul-de-sac. They're doing great. If you take a Norco pill, okay, which is a narcotic pain medication, it's an opiate, but it's pretty low dose. It will come into this receptor and it'll like, maybe drive a little circle in a delivery van. It's not going to cause havoc, but it's kind of in the way. It's filling the cul-de-sac some, and then it'll drive out. No big problem. It didn't tear anything down, okay? If you bring fentanyl into that receptor, this is what the cul-de-sac looks like. Okay, this is a party. I understand this is a picture of a party at Boulder University or Boulder, Colorado University. What is it? Colorado State in Boulder. Anyway, party school. So here they are going crazy in the cul-de-sac. This is what your receptor will look like if you put fentanyl in it. There will be people hanging off the roofs. There will be chaos everywhere. The cul-de-sac will be so full of people that it could potentially cause an overdose, that the cul-de-sac cannot function at all. All right. So what does buprenorphine do? Buprenorphine comes to this cul-de-sac and it builds a gate. So I want you to envision a security gate being built across the front of this cul-de-sac. It's a nice, secure gate. It's hard to get through, and it's got a security guard on it who says, no party here. So fentanyl is sitting, the gate is shut. The security guard, buprenorphine, has shut the gate. And when fentanyl comes down the cul-de-sac, comes down the road and tries to turn into the cul-de-sac, buprenorphine says, hey, no party here. Keep moving. And that fentanyl will move away. Okay. So if you are taking a buprenorphine product and you relapse onto fentanyl or any kind of opiate, buprenorphine, Subutex, Suboxone will block that gate and have that security gate and not let anybody in. Okay. So it actually helps prevent overdose death. Now, the opposite can happen. So here we have this lady throwing this gentleman out. Okay. If fentanyl is in the cul-de-sac already, sorry, I'm trying to limit this. If fentanyl is in the cul-de-sac already and Subutex shows up, it will build the gate. It will grab the fentanyl by the leg, throw it out of that receptor, and slam the gate shut. That feels terrible to these patients. So that's called precipitous withdrawal. And that's what happens when you give these medications, Subutex, Suboxone, too quickly after someone has used an opiate. It will throw them out of that cul-de-sac so fast that it will make the patient feel extremely sick, similar to how they would feel if they had been given a Narcan dose. So they will tell you, I'm allergic to Suboxone. And I always say, you're not allergic to Suboxone, you're allergic to fentanyl. The fentanyl and the interaction with Suboxone is what felt bad. The Suboxone was doing its job, kicking the fentanyl out. It was trying to protect you. So it's the fentanyl that made you feel like crap, not the Suboxone. And oftentimes, I even show them that display of the cul-de-sac concept. So people understand, like, hey, it wasn't the Suboxone that made you sick. It was the fentanyl that made you feel so bad. It was the fentanyl leaving the cul-de-sac that made you feel so bad. Because if that happens too rapidly, it's not a good feeling. So this is just a diagram to show you guys what the buprenorphine is, the yellow line, okay? And let me check time again, because I, again, love to go too long. The yellow line shows that when you take buprenorphine, you get to a certain limit where it just flattens out. It has what's called a ceiling effect. And that ceiling effect means that even if you take more buprenorphine, it's not going to cause respiratory depression. It's not, you would have to take huge quantities to cause any kind of overdose. And it would have to be somebody who's opiate naive. So like if a child or a dog got into this medication, or somebody who had never taken an opiate before, they might feel somewhat intoxicated on buprenorphine. Somebody who has an opiate use disorder, who has been taking fentanyl or taking large doses of opiates, they're not going to feel intoxicated on buprenorphine. And I'll have people say, well, they misuse it all the time. Okay, but you know what? They're not intoxicated on it. And one of the big things I talk to my patients about is do you feel high? Because they'll say to me, my grandma says I'm just trading one drug for another. And I always say, okay, well, do you feel intoxicated? No. How do you feel on this medicine? Is it making you sleepy? Is it making you, fall asleep in the middle of the day, doing things that you did when you were actively using? No. Okay. Then it's not trading one drug for another because it's not the same thing. You can see this orange line is what happens with a full agonist like morphine or heroin. And those things, they can definitely cause enough intoxication that they cause respiratory distress, which would be an overdose, and they can cause death. They sit totally differently in the receptor, in the cul-de-sac. All right. So then let's talk in more detail about, is buprenorphine just trading one addiction for another? Addiction is the use of substances regardless of harm and consequences. Okay, so that defines addiction. Dependency is where a medication is in, or any substance is in your body that may cause a physical withdrawal if you stop taking it. I am physically dependent on caffeine. If I stop taking caffeine, which is the most widely abused stimulant in the United States, I will go through a withdrawal process. I am dependent upon it. Am I addicted to it as well? Yeah, because I know I take too much caffeine, but I use it regardless of the harm and consequences. Now, you could be addicted, or you could be dependent, or I'm sorry, you could be addicted to your cell phone. But if you lost your cell phone, would you actually go through a physical withdrawal? Like, would your body withdraw from your phone? Not a physical withdrawal, even if it feels like that for my teenagers when they get grounded from their phones. So that's addiction is the use of substances regardless of harm and consequences. If you are taking your Suboxone or Subutex as recommended, that is not addiction. You might be physically dependent upon it, but it's not an addiction because you're not using it regardless of harm and consequences. Treatment does not cause the loss of control that use causes. Active use is chaos. It's constant cravings. It's doing illegal activities to obtain these substances. It's destruction of your life. Treatment does not do that. Utilizing a program where you are being prescribed medications for your opiate use disorder does not cause chaos. You're not having to do illegal activities to obtain these substances. There's no destruction of your life. You're able to work, parent, and play. And that's one of the things we talk about in our program a lot. Are you able to work, parent, and play? And it does cause physical dependency. There will be a withdrawal if a patient comes off these medications. But patients who engage in long-term treatment have a lower risk of death by overdose and a higher engagement level with care and services. That's a big difference. I mean, you are more likely to survive your substance use disorder if you are engaging in long-term treatment program. Now, I want to take a moment to just address the caveat. You do not have to use Subutex, Suboxone. You don't have to utilize medications. There are plenty of people who do abstinence-only based treatment, okay? That works for some people, but patients who are utilizing these medications to treat opiate use disorder are more likely to not have a relapse, and they are more likely to have they have a lower risk of death by overdose than abstinence-only patients, because the withdrawal or the relapse risk is much higher for patients who are utilizing abstinence only. And so that's a bias sometimes that you really got to wrap your mind around, because we learned in the opiate crisis, right, back in the day, to not totally trust the medical community, right? We were the ones prescribing oxycodone to everybody. Oh, you broke your toe? Have some oxy, back in the, what was that, early 2000s. That was bad medicine. That was wrong. And the medical community is trying hard to make up for that. But when it comes to these medications, if abstinence only is what the patient wants, then we'll try it, with always the caveat of what safety parameters need to be in place in case of an issue. So I'm just checking the chat to make sure there's nothing too crazy there. I don't think there is. So we'll go on. Maybe. There we go. So let's talk about dosing then. So with these medications, the research is supporting that the higher dose buprenorphine predicted better retention in treatment compared with those that were on the lowest dose. So I'll have moms that are like, okay, I'm only going to take the bare minimum of this medication. Okay, that's fine. But I always tell them you need to be thinking about what's the safest thing for you. So if taking 4 milligrams a day works for you, and that's keeping you safe and sober, all right, let's do that. But if you feel like you need more medication, taking 16 milligrams of buprenorphine a day beats the crap out of fentanyl every day. So if it's coming down to a relapse or taking 32 milligrams of buprenorphine a day, take the 32 milligrams. The fentanyl absolutely can kill you. And for patients who have been sober for more than 5 days, their tolerance for fentanyl starts to go down. So you'll see patients who have been incarcerated for very short periods of time, like 2 weeks. They get out, first use, overdose, die, because their tolerance has gone down while they were incarcerated. You'll see the same thing with patients who will detox. They'll leave detox after 5 days, and they're at really high risk for relapse right when they leave. And if they do relapse at that point, they're very, very high risk for an overdose. So that's why we always make sure we prescribe Narcan to every person that comes into our programming. And I give them refills, and I just throw Narcan at everybody because Narcan saves lives. Okay. So let me move the box again because I think it will block it. There we go. So the dosing within our program, within choice, we give anywhere from 2 milligrams a day to 24 milligrams a day. We don't usually go up all the way to 32. I'm not opposed to it. We just haven't really needed to yet. Most patients start with us between 12 and 20 milligrams total a day. And the pills come in 8 milligram, 2 milligram, or 8 milligram increments. So you can divide that 8 in half. You can divide it 2 in half. You can play around with the math and fractions. I'm not going to bore you with fractions on this talk, but you can divide those medications up. So how do they divide it? Very rarely do I get someone who's taking a dose once a day. And that's something I've really run into with incarcerated patients is they'll say, well, we're only allowed to have med pass once a day. That's generally not the best coverage for these patients. The most common, especially in pregnancy, is to get a dose in the morning and a dose at night of these medications. So if they're taking 20 milligrams a day, maybe they're getting part of it in the morning and part of it at night so that it works the best for them. 3 times a day is less common, but that does help some patients. I do have, occasionally I'll get somebody who has been taking fentanyl 8+ times a day. They're used to maintaining their substance use disorder constantly. And sometimes those patients really benefit from taking their medication really frequently because they're used to this kind of high maintenance part of their recovery. And if I'll say, okay, take your medication, divide it up. So over the course of the day, you take, 4 equal doses. Usually as they are finding more and more recovery, they will reduce those doses. So they'll get down to taking it twice a day, sometimes once a day, because as they're getting sober and they're getting re-engaged in their life, they don't have time for that maintenance anymore. And they'll start to really get more focused on, okay, I'm working. I'm going to go down from 4 to 3 times a day. I'll divide up the same dose, but just 3 times a day. And then I'll 2. So that just kind of naturally seems to get down to a point where most patients end up on a twice a day dose. So when do we wean them off this? I get a lot of questions about weaning. People get really into the concept of weaning. I'm going to tell you this. Weaning is very individual, just like recovery. Everybody's recovery plan is different. I really dislike recovery programming that has a one-size-fits-all method because what works for you, I'm really glad it worked for you. I'm so glad it worked for you, but it is not going to work for everyone. I've met people who they had a substance use disorder when they were 18 years old. They found sobriety. They had 1 round at rehab. They got sober and they never used again. Awesome. That's great. That's not how it's going to work for everybody. So one size fits all is never the way to provide recovery services. It has to be individualized based on the needs of the people we serve. So when you think about weaning, you need to think about it like this. The concept of your medicine has been working well. Let's say your depression medicine has been working well. You can work, you're parenting again, and you feel connected. So we want to wean you off of it. Well, what if that's what's helping all those things work? What if you still need it in your life at that time? Everybody's situation is different. There are some patients who, after they deliver their baby, they're ready to wean. We have those conversations. And when you do medically wean someone, it just has to be done very slowly. I always tell my patients to give yourself grace. If you are not in a phase of your life where it would be a good idea to bring home a puppy, it's not a good time in your life to wean. what I mean by that, I'm being playful when I say it, but what I mean by that is like, is your housing stable? Are your finances fairly stable? Is your time fairly stable? Is your baby fairly stable? Okay. If they have a newborn who has not slept in months, like it feels like that sometimes with a newborn, they do sleep, but it feels like sometimes like they don't. And you can really feel so discombobulated, like you're just on survival mode. That's not a great time to wean the medication that's helping you stay alive because a relapse could kill you. So these weans need to be done very slowly with lots of grace. I always tell my patients, be as nice to you as you would be to your best friend. You know, did you just get divorced and lose your job and lose your housing? Maybe this isn't the moment that you wean your medication. Maybe next month will be better. So definitely slow and steady is the best way to wean these medicines. Oftentimes for these patients, the last 2 milligrams can be the absolute hardest to wean. And so we really talk about that and make sure that we have a plan in place for them that meets their specific needs. So weaning during pregnancy is absolutely not recommended. Everything that the American Academy of OBGYNs say, and if you Google ACOG, ACOG, yes, ACOG, and opiate use disorder, it has all the recommendations. It's an article, probably it's like 14 pages long. It is a lot of medical jargon, but you like small font, you do you, read it. Please read it because I've read it and I literally go through it with a highlighter sometimes because I find that I really have to highlight things when they're written like that to be able to pay attention to them. I, yes, obviously have an attention span issue. But prenatally, weaning of any kind of medication to treat opiate use is not recommended. If they're utilizing methadone, they are absolutely not recommended to wean. If they are utilizing Subutex Suboxone, absolutely not recommended that they wean during pregnancy. The outcomes are too high risk. And I educate my patients about this during pregnancy because I want them to understand. A lot of my patients come to me and say, I cannot wait to wean my medicines. And I'm going to wean during pregnancy, so I don't have to worry about this after I deliver my baby. But the risk factors and the risks of overdose are so high that weaning those medications is often a horrible idea. I've had 2 patients try to wean themselves. And when one of them overdosed to the point where she came in on a gurney with them giving her chest compressions with her big 36-week pregnant belly, and they're giving her chest compressions on the gurney. I mean, it was horrible. And I had one other who also overdosed, but was reversed very quickly. It's very high risk to try to wean during pregnancy. Once baby is born, I don't even ask them if they want to wean until their baby's at least 3 months old. Now, if they bring it up, I will always talk to them about it. Because if a patient, their baby's 3 months old, they come to me and say, I want to wean. I say, great, let's do it. You're the boss. Let's make it happen. Are these things in place? Safe housing, stability in your life, stable enough. And then we talk about, okay, what's that going to look like? We're going to try to cut 4 milligrams out for 2 weeks and see how that goes. That goes great. Let's try 4 more. If that doesn't go great, let's hold for 2 weeks. You know, and we really work out a plan that has 2 steps forward and 1 step backwards built into it. Overall, we make forward progress. So how long should patients be on Subutex or Suboxone, any of these buprenorphine products? The recommendations within the treatment community that the addiction psychiatrists that work at the hospitals I serve, their recommendation is 5 years. But in this article that I found, in this research article, it said at least 2 years. So if they had taken buprenorphine for at least 2 years, had better chances of successfully discontinuing that medicine than those who had shorter treatment histories. If they're taking this medicine for 2 years, they're engaging with a provider on a really regular basis. And they're getting services on a really regular basis, which means that they're engaging in their care and their recovery journey more closely. So that is definitely something to think about. So guys, I have some books here that I really want to talk to you about. These are some of the books that I feel like have really changed the way that I have encountered this information and been through it. Again, I mentioned to you that I don't have a lived experience myself as either a child of a house with substance use disorder or my own lived experience with substance use disorder. And so as I'm trying to learn, one of the books that I read was this book by Nikki Sixx, who, yes, is the bass player for Motley Crue. Okay. Now, I was born in the late 70s, so I grew up with like hair bands like Motley Crue and Poison and all those bands. So, but I never thought I'd read a book that one of them wrote, right? Nikki Sixx's book, Heroin Diaries, is wonderfully written. He he's publishing the journals that he wrote when he has a heroin use disorder, history of heroin use disorder. He's been sober for a long time. And he's writing about those times when he was actively using. And these are the journals he wrote during that time of his life. So he has pictures. I love books on Audible, but that book needs to be read in a paper format. I love paper books too, but there is nothing that makes everyone in my house have to ask me a question more than if I try to pick up a paper book. So this one though needs to be read on paper. You need to hold it in your hands because there's so many pictures in the book. He talks about things like when he was actively using, if he ran out of heroin while he was on the road with Motley Crue, he would inject Jack Daniels. He would inject Jack Daniels. The nurse in me like has a nervous breakdown thinking about how non-sterile it would be to put Jack Daniels into your vein. But he said that's what they did. Like that was just part of his partying in those days. He overdosed once on heroin, and this was before there was Narcan. He got picked up by an ambulance. They called for help. The ambulance came, they picked him up. He had no heartbeat. They were giving him CPR. And Nikki Sixx writes about this. He says that the guy in the ambulance, the EMT, was a huge Motley Crue fan, and he recognized Nikki Sixx, and he gave him some crazy quantity of epinephrine, which was what they would give you back then before they had Narcan. So he's injecting epinephrine into Nikki Sixx's heart, trying to get him. And he kept saying, he's not dying on my ambulance. And he finally got Nikki Sixx's heart to beat again. And that was the song Kickstart. Is it Kickstart My Heart? Yeah, that's right. Isn't it Kickstart? It's not Jumpstart. Kickstart My Heart. That's what that song is written about, was when Nikki Sixx overdosed and the ambulance drivers were just like, not dying today, bro. Nikki Sixx said that when he went to the hospital and he was discharged, okay, so he was, the heroin got out of his system. He was breathing again on his own. They discharged him. He immediately drove back to his house and shot up heroin the second he walked in the door. That's how sick he was at that time with his addiction. And it's really interesting to hear him talk about it. I'm really trying to look at the chat here, make sure there's no other questions. Definitely put your questions in there. Beth Macy has done 2 different books. One is called Dope Sick and one is called Raising Lazarus. The Dope Sick one is more about what got us there, like what caused the opiate epidemic in the first place. And you heard me talk about that originally doctors' offices were prescribing these medications. And that Dope Sick talks about that a lot. This other book, Dreamland, also talks about that a lot. How we got here. I love both those books. If you're going to read one of them, read Dreamland. That was one of the best books. I don't know if anybody can put a message in the chat if you've read Dreamland or not. That book was one of my very favorites about opiate use and kind of how we got here. I love root cause analysis, and Dreamland really talks about how we got here. Raising Lazarus and then also The Least of Us are both books about fentanyl and the epidemic that's had on our country. This author with the blue cover here, Chasing the Scream. Okay, so this gentleman's name is Johann Ari. Okay, Ari. So my brain says Joanna when I read it, even though there's no A on that, or at the end. Joanna Harry is how I read it. And then I'm like, wait, it's a guy. And his name is Johann. So my brain just didn't know how to say those words. So Johann Hari does a book called Chasing the Scream, which is unbelievably good. It's about the war on drugs and how different places have done different things to try to fight the war on drugs. And it's beautifully written. It's very much in a storyteller type format. I love that book. Now, if you work with high-risk patients or high-need patients in any way, I really want you to read at least Compassionomics. This book is so well written, and it really talks about having services from providers who actually care about what happens to you greatly impacts your long-term outcomes. I feel like that's kind of like a no-duh, to use a term I would have used in my youth, but this book really makes it true. It does this very specific, detailed analysis about case study to prove to you that if you are nice to people, they have better outcomes. They do better. That's a pretty big deal. Dopamine Nation is a book about dopamine release in our brains and how, but it's written in a very obtainable way. Again, I hate medical journals. I read them because I have to, but I don't enjoy them. Dopamine Nation is written about how dopamine releases in our brain, and it has a big impact on substance use disorder. High Achiever is a book about a patient who, it's about her firsthand experience with substance use. She's Tiffany Jenkins is extremely funny. I follow her on social media. She cracks me up, but she was a ferociously manipulative substance use disorder person when she was actively using. And she talks about how she did the things she did. And it's pretty interesting, gives a lot of insight. Canary in the Coal Mine is about the true story of what happened in a small town in central India or southern Indiana, where they had the largest HIV epidemic in the country, and how that stemmed from shared needle use. And this doctor, Dr. William Cook, fought that battle. It was unbelievable. He is a warrior of helping these patients. Okay, so I'm reading some of the comments here, and one of them is, what are your thoughts on addressing the shame that these women feel while using when pregnant? Man, I just put it right out there. I always address that, immediately say to them things like, congratulations on your pregnancy. Because oftentimes no one has congratulated them on being pregnant. Many people have treated it as like, oh my God, how could you be pregnant right now? Instead of, this new life is a celebration. Let's celebrate this baby. I also talk to them about, you care so much about your baby that you're seeking care, that you are ready to find recovery. You're ready to start working a program because you care so much about your baby. I try really hard to make it strength-based, but we also have therapy embedded within our program because these moms got to work through the guilt. They got to work through positive disciplining techniques. They got to work through all these connection points and how to fix the trauma that they experienced to make sure that that generational trauma doesn't continue for their children. They've got to do so much work in order to parent these kiddos. We need the therapists in place. We actually do teach our moms about attachment parenting specifically because they often have attachment disorders based from their childhoods. So we really address the guilt that these mamas feel when it comes to substance use disorder and using when pregnant, because they'll say, how could I do that to my baby? And we say, okay, like the peer recovery coach that works in our program, she's a former graduate many years ago who maintained her recovery over several years, and we then hired into our program. And she really helps them address like how that guilt works in you as a mom, and how to, it doesn't mean it's going to go away, but how to work with it. Let's see, another question. Oh, somebody's talking about Canary in the Coal Mine. That is a great book. Yeah. So, all right. Definitely, guys, if you have any other questions here, let's keep, I think I've got, let me make sure that I'm continuing on. So there's my Archie. That's my little long-eared bunny that I'm obsessed with. Here is my personal email. So if you guys have any questions for me, definitely, or if you have any discussion points, feel free to reach out to me. And let me see if there are any other questions in the chat, and feel free. Oh, there's a link to a tool for addressing stigma. That's fantastic. Yes. And there is so much stigma in the care of these patients. Absolutely. All right. So definitely post any other questions you have. Yes, Archie's so cute. I love him. Look at his little face. So please feel free to come off mute if you have any questions, or definitely put any more questions that you have in the chat.
While y'all are thinking about any additional questions, I'm just gonna put the link to the evaluation of this webinar in the chat. If you could fill that out for us, we would greatly appreciate it. I'll send it via email as well if you need to hop off, but here you are. Yeah, we'll give it a couple more minutes for questions. Brooke, it looks like one did pop up in there.
Yes.
What are your thoughts on methadone?
Okay. Not every patient has the same recovery journey. I always say that in my head. So my instinct, I have bias against methadone. I feel like, oh my gosh, patients can become intoxicated. I had experiences. I was a NICU nurse when I was an RN, and I would see moms who were falling asleep at the bedside, who were on extremely high doses of methadone. I had a lot of bias about methadone when I was a nurse and was caring for babies at the bedside. As I've learned more about methadone, I understand methadone is our oldest medication to treat substance use disorder. We know the most about it. We have the most research because we've been using it since the 70s. So we know a lot about methadone, and it works for some patients. So if it works for them, great. If it's their recovery journey, then we can absolutely utilize methadone. The problem with methadone is you have to go daily to a methadone treatment center to get your dose. I can't, as a prescriber, be in an office and give you a prescription for methadone, but I can give you a prescription for Subutex or Suboxone. You don't have to come for daily dosing. Daily dosing is impossible in rural communities with poor transportation. There are many, many, many barriers to methadone. But if a patient feels like methadone is the right match for them, it's a tool in the arsenal, and it should be used when necessary. And we know, as far as for babies, like in pregnancy, patients who are utilizing, babies can have withdrawal from these substances when they are born, okay? So we know that babies whose mother is utilizing methadone have a higher risk of having withdrawal that's so significant that they need medications in the NICU to treat it. But if it's keeping them sober and alive, again, methadone beats the crap out of fentanyl. And that's what I'm always saying to myself when we're like, okay, she's taking methadone. Is that really well, it's definitely better than fentanyl. And so asking the question, is this better than fentanyl? The answer is yes. Then that is important. It needs to be taken into consideration. Fentanyl is in epidurals. Absolutely. The fentanyl that's in an epidural, though, is hospital grade, pharmacy grade fentanyl, highly controlled. The doses are nothing like the illicit fentanyl that they're getting from off the street. Nothing alike. So I will have, and then this is something too that people get real touchy on. They're like, well, what if she's having a C-section? Can she have pain control? Yeah. Dude, have you had an open abdominal surgery with no pain control? Like, that's torture. We don't do that to people. Like, we did that in the Civil War, right? Like, bite onto this while we cut your leg off. We don't do medicine like that anymore. So patients can absolutely have pain control during delivery, a vaginal delivery or a C-section. That would be inhumane to not give people pain medication. We just talk to them about it ahead of time. Most people who have a history of substance use, the opiate use disorder, they don't respond very well to opiate pain medication. So people will say, well, you're going to trigger a relapse in them. That's not statistically what the research shows. If you give someone a dose of fentanyl in their epidural, that's not going to send them into a full blast relapse. You're not sending them home with a script for it. You're giving them one controlled dose in a hospital. That doesn't cause substance use disorder. That doesn't even cause relapse. It's talking to these patients ahead of time, though, because I'll have patients that are like, I can't see a positive fentanyl on my drug screen or I will go crazy. I will lose it. That is too triggering. And I say, okay, then fentanyl is off your list. And I'm a big believer, because I'm a former NICU nurse, that a laminated birth plan is always a bad idea. You need to have a birth plan that's really flexible, that has a lot of, if this happens, then I'd like to see this happen, but I understand that this may be a possibility, right? You got to be flexible, because babies decide what happens at birth. Mamas can have goals. And so in the choice program that I run, we always talk about, what are your birth goals? My goal is that I would like to have no fentanyl. Okay, that's a very reasonable goal. My goal is that I'm going to have a vaginal delivery with no pain medication. Great. If that doesn't go exactly like that, what's your thought process about using an epidural? Would an epidural make sense for you? What are they going to put in the epidural? Well, they have lots of things they can put in the epidural that are not fentanyl. Okay, that would be my goal. Okay, if you do have to have a C-section, who do you want in the room with you? Sometimes my patients are extremely triggered by the lack of ability to move. Like, they feel very physically restrained if they get an epidural that allows that they can't move at all. And so that's one of the things that scares them, and we talk about that. Okay, what is that going to look like for you? We just talk a lot about education. This is where doulas become wonderful, is that when you bring a doula into the equation, they can really be part of helping these mamas work through, what is this birth experience that you want? Where are you flexible? And we're always going to keep the baby as the goal, because we're all on the same team. The medical team and the mama are on the same team. And so we always are working together to figure out what those goals are. And that question about the fentanyl and the epidural is a great question, because I've definitely had mothers who were like, absolutely no fentanyl. And I understand why. What other questions do you guys have for me? I have a few more minutes here and want to make sure I'm answering anything you guys want to know. Anything else? All right. Well, you've got my contact info. You can also message me, or if you have any other questions, definitely reach out to Jordan. She can always send me a question. I'm glad to answer any questions you have.
Thanks so much, Brooke. I'll follow up via email, and thank you all so much for being here. Sounds like everyone really enjoyed this. So yeah, hope you all enjoy the rest of your day, and thanks again, Brooke. Bye, y'all.